Assalamu alaikum dear candidates. I am Dr. Nadia Kanval, gynecologist and online teaching mentor. Now we will discuss few MCQs and the best answer in them. Now the question is, which of the following is a complication of the third stage of labor associated with forced placental separation? So either it is endometritis, or it is uterine atony, or Asherman syndrome, or uterine inversion. So you see, we are having forceful placental separation. So it will result in, you must see here that it can, the complication because of this can be uterine inversion. So the correct answer in this regard is uterine inversion. Because of the forceful separation of the placenta, this results in uterine inversion, and the steps of replacement of uterine inversion are you must know, and it is basically an obstetrical emergency. And in this regard, the rest of the things which are endometritis or uterine atony, these are, although the uterine atony is the complication of third stage of labor, but it's not associated with forceful separation of the placenta. So uterine inversion is actually associated with the forceful removal of the placenta. Now, what is the half-life of oxytocin? You know that half-life of oxytocin is very short. That is why it is given in case of augmentation. It can either be, now the options are 5 minutes, 30 minutes, 3 hours, or 2 days. So as I've told you that the half-life of oxytocin is short, so it's actually 5 minutes. That is why we can easily titrate the dose of oxytocin, because the half-life is short and it's easily removed. Now, what is serious potential complication of prolonged oxytocin administration? Either DIC, or water intoxication, or myometrial necrosis, or hyperkalemia. So you know that prolonged oxytocin administration ultimately results in water intoxication, because the water is retained inside the body, and ultimately in hypertensive patients we administer oxytocin with vigilant monitoring, because there is side effect of water intoxication in this case. Now the question is, which of the following is associated with ergonovine and methyl ergonovine? It is actually ergometrine. Now, ergometrine is the association either seizure, hypertension, oliguria, or thrombocytopenia. So we know that with ergometrine, hypertension is the associated complication. So again, we must know that in hypertensive patients, we have to administer ergometrine with vigilant monitoring of the blood pressure, as it may result in hypertension. So if the patient is already hypertensive, then the patient may develop crisis because of administration of ergometrine. So there should be a vigilant monitoring of the patient in this regard. Now the question is, what is the major advantage of a mediolateral episiotomy? Either easy surgical repair, or less post-operative pain, or the fewer third degree extensions, or the less blood loss. It is also a very important Viva question and also the MCQ question. So the answer is, there is in mediolateral episiotomy there is fewer third degree extension, or you can also say that there is less anterior wall laceration chances in case of mediolateral episiotomy. So ultimately, this is the advantage of doing the mediolateral episiotomy, to avoid the third degree extensions. Now coming towards the next question, as I have told you that what is a laceration involving the vagina mucosa, skin, perineal body, and external anal sphincter called? So either it can be first degree, or as you have all studied the degrees, either first degree, second degree, third degree, or fourth degree. So you must be knowing that what are the various degrees, and you know that when external anal sphincter is torn, it is actually third degree. Now third degree, all of you know that it is further categorized into A, B, C. So generally speaking, the third degree tier is actually involving the external inner sphincter. Now the next question is, when performing the clinical pelvimetry in a gynecoid pelvis, the diagonal conjugate should be at least how many centimeters? Now the options are 7.5, 9.5, 11.5 or 13.5 or 15.5. Now the diagonal conjugate value is about 12.5. It should be 12.5 centimeters. So the option here, the most accurate, is actually 11.5 centimeters. We cannot say less than that, because it ultimately this will result in the contracted pelvis. So at least how many centimeters? It should be around 11 to 12 centimeters. So the correct answer in this regard is that the diagonal conjugate should be almost 11.5 centimeters. And if it is less than that, then ultimately we will refer it as a contracted pelvis. And rest of the values, these are showing the above values are showing the contracted values pelvis, and the remaining values, they are very abnormally raised. Now we have cleared this question, and then coming towards the next question. A gradual decrease in the fetal heart rate that coincides with the uterine contraction describes which of the following deceleration types? Now, either it's late, it's variable, early, or prolonged. So you must know that the deceleration, the which coincides with the uterine contraction, is actually the early deceleration. If the fetal heart rate gradual decrease persists even after uterine contraction has gone, then it is actually a late deceleration. And if it has got no relation with the uterine contraction, then it is variable deceleration. So here, as it is coinciding with the uterine contraction, so it is early deceleration, and it is the cause is mostly because of head compression. And this occurs in case of the uterine contraction, when because of the when because of compression of the head there is deceleration, and it is because of the uterine contractions. And if the fetal heart if fetal heart is decreased, and even if there is no more uterine contraction, it is persistent, then it is actually called as late deceleration. And further, then coming towards the next question, a 23 years old nulliparous D negative patient at 37 weeks gestation undergoing external cephalic version with breech presentation, which of the following should be done? The option is, either we go for the nifedipine or magnesium or oxytocin or anti-D immunoglobulin. So you know that she is anti-D. She is the blood. The patient is having blood group negative, and RH negative blood group. If in this regard, definitely the main theme of management is that we have to give anti-D immunoglobulin in this patient. So because why? Because there is risk of um, uh, antigen antibody exposure during this case, and ultimately this can be fatal in case of the next ongoing pregnancy. So we have to administer anti-D immunoglobulin. Thank you.